In this video, we will discuss enhanced myometrial vascularity diagnoses, focusing on perioperative planning and the use of hysteroscopy in management. After this video, viewers will be able to define enhanced myometrial vascularity and understand the associated risk factors, to recognize the potential of hysteroscopy in its management, and to understand the importance of perioperative planning. An arteriovenous malformation is defined as abnormal anastomoses between arteries and veins, leading to focal, tortuous, high-flow vascular lesions. Uterine AVMs are either congenital, which are extremely rare, or acquired, now referred to as uterine enhanced myometrial vascularity, or EMV. The prevalence of EMVs is roughly 1.5 to 6.3%, and commonly occur in the context of previous uterine procedures, pregnancy-related complications, or other causes such as infection. In our experience, EMVs often occur in the context of retained products of conception with underlying adenomyosis or infection, secondary to the increased vascularity with the retained products acting as a focal point. Historically, the gold standard for diagnosis was angiography. However, transvaginal ultrasound with color Doppler is now the preferred imaging modality. Ultrasound criteria for diagnosis of EMVs include tubular or vascular-like structures that display a color mosaic, presence of focal areas of marked vascularity extending into the myometrium, high peak systolic velocity, and other specific Doppler characteristics. Of note, extension of the vascular mass into the myometrium is a key differentiating feature between a uterine EMV and retained products alone. Options for management include conservative, medical, uterine artery embolization, and surgical. Management must be individualized based on the patient's hemodynamic status, symptoms, clinical context, imaging findings, and desire for future fertility. We will use the next case to demonstrate an approach to perioperative planning and the use of hysteroscopy in the management of retained products of conception with suspected EMV. This case focuses on a 28-year-old G1P0 who underwent an elective D&C for therapeutic abortion at 6 weeks, 3 days gestation. She then presented postoperative day 7 with retained products of conception and signs of infection. Her ultrasound described a thickened and echogenic lesion at the uterine fundus consistent with retained products of conception. There is a focus of vascularity which demonstrated extremely high velocity of up to 161 centimeters per second and arterialized venous waveforms, concerning for the presence of an AVM. Let's start with preoperative considerations. Step 1. Confirm diagnosis and management options. You can begin by discussing the case with radiology to clarify their index of suspicion. Then consult IR for consideration of preoperative embolization. And finally, review management options with the patient. Step 2. If the patient wants to proceed with surgical management, appropriate consent needs to be completed. Standard surgical risks associated with hysteroscopy should be reviewed, as well as case-specific risks, including placement of an intrauterine balloon, uterine artery embolization, increased risk of blood transfusion, conversion to laparotomy, and possible hysterectomy. Step 3. After obtaining consent, appropriate preoperative planning should be completed to optimize the patient and OR environment for success. Based on the degree of concern, possible preoperative considerations include a preoperative anesthesia consult, adequate IV access, including 2 large bore IVs, and a possible arterial line depending on anesthesia preference, preoperative blood work including a CBC Titan screen, cross-matched blood products on standby in the OR, and ensuring your surgical table is set up with all necessary equipment, including a diagnostic and operative hysteroscope, a resectoscope in the event electrosurgery is needed, plus or minus a laparotomy tray in the room. And finally, a dose of tranexamic acid can be given preoperatively. Now for intraoperative considerations. A hysteroscopic approach carries the following 2 advantages. It allows for accurate diagnosis and safe intraoperative decision-making, as well as targeted resection of the pathology. Step 1. Inject vasopressin at the cervicouterine junction. Our preference is to use 10 to 20 cc's of 20 units of vasopressin in 100 cc's of normal saline, injected on either side of the cervix. Please note volume, dilution, and injection sites used may vary according to surgeon preference. Step 2. Use a 3 mm hysteroscope to hydrodilate the cervix to avoid blind dilation and potential vascular injury. Step 3. Adjust the fluid pressure to maintain a clear field and perform an inspection of the cavity. As you can see here, there is a significant amount of retained products, primarily arising from the fundus and left lateral aspect of the cavity. Step 4. Remove the hysteroscope and switch to a 5 mm operative sheath. Again, hydrodilation and direct visualization with the hysteroscope is preferred. Blind dilation should only be completed if necessary by advancing the dilator to the internal os and no further. Step 5. Use the mechanical tissue removal system to perform a targeted and gentle resection of the retained products. As you can see here, we start resection from the outermost edge and work our way circumferentially to ensure we maintain visualization and can anticipate if increased vasculature becomes visible. Furthermore, as we near the myometrium and the base of the specimen, more targeted resection is performed, highlighting the advantage of a directed hysteroscopic resection over a blind procedure. Step 6. Inspect the final cavity to ensure hemostasis. Step 7. If you have concerns with hemostasis, you can perform a bimanual massage, give uterotonics, or insert a pediatric catheter to provide tamponade. Once the case is complete, other important postoperative considerations include mitigating ongoing bleeding risk with additional doses of TXA and repeat CBCs as needed, and mitigating infection risk by following up any swab results and continuing antibiotics as clinically indicated. In summary, we hope the takeaway messages from this video are that 1. While EMV/AVM diagnoses are frequently overcalled based on preoperative imaging alone, it is important to understand the diagnostic criteria and risk factors that may heighten your suspicion. 2. Appropriate patient counseling and preoperative preparations are critical in the event of complication. And 3. A hysteroscopic approach allows for safe intraoperative decision-making and targeted resection. Thank you.